Welcome, everyone. I'm Debbie Lindis, the Healthcare Delivery System Group Manager at the Office of Healthcare Affordability, or OCA, which is housed within the Department of Healthcare Access and Information, or HCAI. I use she, her pronouns, and we are super excited to convene this work group today and embark on the HCAI Health of Primary Care in California Snapshot with you all. So today we'll start with introductions and review some meeting logistics. Next, we'll present an overview of the snapshot to introduce everyone to the project and the goals for this work group, followed by some time for questions. And then after that, we are so pleased to have Barbara Rabson, Aaron Bonney, and their teams here to share their experiences and lessons learned from work implementing the Massachusetts Primary Care Dashboard. And we'll have time for Q&A after their presentation. And then we'll wrap up by reviewing the topics that we plan to cover in work group meetings this coming year and HCAI's next steps on the snapshot. So I'll start by introducing the HCAI Snapshot project team. The Snapshot's a collaborative effort across HCAI involving our Office of Health Information, Office of Health Workforce Development, Office of Healthcare Affordability, and Office of the Patient Advocate. So through this collaboration, we can leverage expertise in data, workforce, spending, equity, and quality across all of the HCAI offices. And each office has a representative working on the snapshot who can please introduce yourselves in the chat. And then we also are grateful to have the support for the snapshot from Friedman Healthcare and Dr. Diane Rittenhouse of Mathematica, who I'll ask to introduce themselves to you now, starting with Diane, if you want to come off mute and introduce yourself.
Diane Rittenhouse. I'm a family physician by training and a health policy researcher, and I was honored to be a part of the advisory board for the Milbank National Primary Care Scorecard and a subject matter expert for the federal scorecard that was created, although never actually came into fruition, or not yet. So happy to see this progress in California.
Thanks, Diane. And next, Vinayak and Mary Jo from Friedman Healthcare will introduce themselves, and then the rest of the FHC team can introduce themselves in the chat. So we can start with Mary Jo.
Thank you, Debbie. Good morning, everyone. My name is Mary Jo Condon. I'm Vice President and Director of Policy and Programs at Friedman Healthcare. Most of my work at Friedman is around supporting states in moving more of the healthcare dollar to high-value services like primary care and behavioral health, and supports several states in primary care measurement, delivery system reform, and also developing dashboards. So supporting work in here in California and Maryland and Rhode Island. So thank you, and I'm excited to be part of this group. Vinayak, turn it to you.
Morning, everyone. Vinayak Sinha here. I'm a senior consultant at Friedman Healthcare, and I've really spent the past decade focusing on value-based care and some of the really high-value services within healthcare. That's often meant thinking about alternative payment models and non-claims payments and how they're being incorporated with a specific focus on primary care and behavioral health. I also lead our work supporting the OCA team, focused on the primary care investment benchmark, as well as behavioral health and alternative payment models. So we're very excited to see this get started, and also support a number of different states on their primary care related data collections, analyses, and dashboards. And looking forward to hearing from the Massachusetts team today as well. Enjoy working with the CHIA team for this work as well.
Thank you. So the OCA team, myself, Margareta, and Miranda will be leading and coordinating the Snapshot project. Miranda and I will be your first points of contact for any Snapshot questions outside of these meetings. So Margareta and then Miranda, can you introduce yourselves?
Hi, everyone. Welcome. Nice to see all of you. Many of you are faces I've known well, and looking forward to getting to know all of you. My name is Margareta Brandt. I'm Assistant Deputy Director for Health System Performance at the Office of Healthcare Affordability. So I lead our work along with a great team on primary care investment, behavioral health investment, and several other areas. And I'll turn it over to Miranda.
Hi, everyone. Welcome. Great to see all the faces to the names I've been emailing for the past weeks, months. My name is Miranda Wirtz. I am the Senior Primary Care Specialist and specifically focused on supporting the Snapshot project. So, Debbie, hand it back to you.
Great. Thanks, everyone. And last but not least, we'll be collaborating with the California Healthcare Foundation, or CHCF, on communications to support dissemination of the snapshot. Carlina Hansen of CHCF is a work group member, and so I'll be having her introduce herself with the rest of the group in just a moment. So now we're looking forward to getting to know all of you. And so for workgroup member introductions, in the interest of time, we'd like you to each share with us briefly your name, the organization you represent, your title or role within the organization, where in California you're located, and something you're looking forward to as a member of the Snapshot workgroup. So I can start with myself. Good morning, I'm Debbie Lindis. I live in the Bay Area, and as a primary care physician myself, now transitioned from practice into policy work at OCA. I'm very excited to collaborate with you all to shape this new tool that will help us use data to motivate action to improve primary care for all Californians. So Miranda will drop these introduction prompts into the chat, and I'll go on to the next slide where we have all of your names and organizations. And what I'll do is just call on you in alphabetical order, and you can come off mute and introduce yourselves. I apologize in advance for any and all mispronunciations. Please feel free to correct me. And then if you wish to share a preferred name or your pronouns, we welcome you to do that. So we'll start with Dr. Raul Ayala.
Hi, good morning, everybody. Happy to be here with you all. I am from Adventist Health System. I am a family physician, and I serve as the ambulatory medical officer. So I oversee all clinics, GME, health equity, and our health plan. And I hope to, well, first of all, it's a blessing to be here with everybody, but I hope to be a collaborative with all of you here, and looking forward to the work. Thank you for allowing me to join.
Thank you. Next, Dr. Eric Ball.
Hey, y'all. Good morning. My name is Eric Ball. I'm a full-time practicing primary care pediatrician in Orange County with a practice affiliated with Children's Hospital of Orange County. I also serve as the chair of the American Academy of Pediatrics in California, and I sit on the board of the National American Academy of Pediatrics. I am so excited to join this group. Primary care is the front line for our healthcare system, especially for those of us in pediatrics. We are overworked and underpaid and burned out, and I'm hoping we can do something about that.
Thank you. Next is Celine Betancourt.
Hi, good morning, everyone. Celine Betancourt, Senior Policy Manager at the California Pan-Ethnic Health Network. We are a consumer advocacy organization focused on racial health equity work in California. I am based in Los Angeles and just looking forward to making actual data, especially during this time of really intense cuts for our health system.
Thank you. Dr. Renee Bravo.
Hi, Dr. Renee Bravo. I am a primary care pediatrician for almost 40 years on the Central Coast, San Luis Obispo, a small 5 single specialty group practice and exclusively pediatric primary care. I'm also the president of the California Medical Association, representing the 50,000 physicians in the state. And I'm really excited about this because, you know, I have to agree with Dr. Ball. Primary care is really in a place of potential crisis these days in the state. I'm really excited about the work of this group and how it's going to put a real significant focus on how we can continue to improve and understand where we're going. So honored to be here and looking forward to working with you.
Thank you. Diana Douglas. Diana here. Maybe we'll come back to Diana. Crystal Eubanks.
Hi, everyone. I'm Crystal Eubanks. I'm the Vice President of Care Transformation at Purchaser Business Group on Health. And also in that role, I lead the California Quality Collaborative. And so we spent many years, and my passion is primary care transformation. And so I'm very thrilled to see this happening. And I think what I'm most excited about this work group is I look at the faces and names, and like these are some of my most favorite kindred spirits. So the fact that we're all in the room, like, gives me hope for going into a new year and more change. And more positive impact. So thank you.
Thanks. Lisa Fulberg.
Hi, good morning. Lisa Fulberg. I'm the CEO of the California Academy of Family Physicians here in Sacramento. And I'm really appreciative to be here and contribute in some way to developing the dashboard so we can see hopefully the great progress we're making in moving toward a more primary care centric system. And I'm also excited about helping to develop a tool that gives us another way to talk to people about the role of primary care, especially those folks who may not live and breathe it the way that many of us on the call do. So thank you again for allowing me to be here.
Thanks. And I will introduce Dr. Kevin Grumbach, who was unfortunately unable to make today's meeting, but he's professor of family and community medicine at UC San Francisco. And next is Carlina Hansen.
Hi, all. Great to see you. Fabulous to see so many familiar faces. Carlina Hansen, I'm a senior program officer at the California Healthcare Foundation. Our offices are based in Oakland and Sacramento. I am in the San Francisco Bay Area. There are a lot of things that I'm excited about. But I think one of them is just bringing these data to life so that folks can engage with the data and get excited about primary care and making change, sort of understanding the impact that we can have here in California. And I'm also excited about leveraging some of the lessons from other states that have come before us. So great to see everybody. Thank you.
Thanks, Carlina. Dr. Susan Huang.
Hi, everyone. Susan Huang. I'm the Chief Medical Officer of America's Physician Groups, representing accountable care physician organizations across the state in California and also nationally. I am based here in the Bay Area, and hello, Debbie, after many years of having been at UCSF together. And I'm most excited really that there's finally potentially an ability to really leverage data and information about primary care and actually drive change in terms of how investments in primary care need to continue to be made in the state. And so really glad to be part of this work group. So thank you.
Thanks. Dr. Edward Jun.
Hi, everyone. Ed Jun. I serve as Chief Medical Officer here at Inland Empire Health Plan, an internist by background. I live here in the Inland Empire, and I'm just really excited and thankful for the opportunity to not only be part of this group, but also think through on how to make this snapshot the snapshot of snapshots. I believe that we have way too many reports, more data than we can probably all consume and wrap our arms around. So just finding a way to create that snapshot and report that drives meaningful difference and meaningful change when it comes to primary care in the right way. So excited to partner with all of you on this journey. Thanks.
Thank you. I will go back briefly to Diana Douglas. I think you have joined. Are you available to introduce yourself?
I am, and I'm so sorry I had some connectivity issues, but good to see everyone here. I'm Diana Douglas. I am Director of Policy and Legislative Advocacy with Health Access California, which is a healthcare consumer advocacy group working statewide. And I am based in Sacramento, California. And, I'm looking forward to being part of this group. I've been a part of work groups with DMHC and covered California on quality and equity measures. And I think of all the sort of span of work I do, I think that has so much potential and is what I really, enjoy working on the most. I think it has so much potential to impact consumers. And I think especially for primary care, a lot of the potential in primary care and how we can improve and monitor quality and leverage it for consumers is lost in some of the bigger conversations. So I'm excited to be part of a collaborative space here to work on those issues. Thanks all.
Thank you. Next is Dr. Melissa Marshall.
Hello, everyone. It's lovely to see so many colleagues on the call. I'm a family physician and the Chief Medical Officer for the California Primary Care Association. Our office is in Sacramento, but I am located in the beautiful Anderson Valley in Mendocino County. I'm always very excited to look at data, particularly to drive systems change in primary care. We know that so many Californians receive their health care in federally qualified health centers, and they need our support more than ever. So thank you for allowing me to be a part of this wonderful project.
Thanks. Next, we have Dr. Todd May.
Good morning, Todd May. I'm a practicing family physician in the Bay Area and Vice President Medical Director at HealthNet. Previously, I was a professor at UCSF for over 20 years, training medical students and many cohorts of family medicine residents who I helped launch into the workforce. I'm very excited about the commitment to the investments that we have to make in primary care, and they're long overdue. And I think having this snapshot and then tracking the impact of those investments over time will be very helpful for us to really build a robust primary care foundation that we need.
Thank you. Jeremy Mice.
Hello, everyone. It's Meese is my last name. It's okay.
Thank you for the correction.
Honored to be the first mispronunciation. So Jeremy Meese, I'm a practicing PA in primary care. I'm the immediate past president of the California Academy of PAs. Professionally, I work and live in Sacramento at a place, an FQHC called WellSpace Health. And I'm the Associate Medical Director of Primary Care and Informatics. So I am especially looking forward towards digging into the data, and I'm a data geek. And so I'd love to distill it all into a dashboard and help move the needle from evidence-based perspective. So thanks for including me.
Thank you. Dr. Sunita Mutha.
Good morning, everyone. Nice to see familiar faces. I'm Sunita Mutha. I'm a practicing primary care general internist at the University of California, San Francisco. I also direct Health Force Center, which is really focused on the workforce in healthcare, from primary care to you name it, any part of the workforce. And we both are, we look at data and try to generate the evidence base to support some of our workforce decisions, and also invest in developing capacity, leadership capacity, particularly. The only other lens I represent here is I serve on the board of directors for Physicians for Healthy California. So this issue is pertinent, and have had the good fortune to work with several of you on the Milbank scorecard. I would say +1 to many of the things that have been said. What I really hope we can do is I have an audacious goal that I would like us to achieve, that we can use this snapshot to really redefine what the role of primary care is in healthcare, to sort of elevate that role, which has gotten lost into what we can count as opposed to what we should value. And I hope that we can be future thinking ahead about the role of artificial intelligence and as it will change practice, and sort of imagine a snapshot for another future that's coming very, very soon.
Thank you. Amy Paulson.
Hi there, I'm Amy. I'm the president of the California Association for Nurse Practitioners, representing 42,000 NPs here in California. I live in Marin County, and I work as a primary care provider in Contra Costa County, doing family medicine and addiction medicine. I work as a hospitalist at a mental health hospital, managing the physical health issues these people have when they're admitted due to their mental health. And then I teach health policy and the Doctor of Nursing Practice program at USF. And very happy to be here doing anything I can to help support primary care outcomes and really showing the value that we can bring. Thanks for having me.
Thank you. And our last member, Dr. Shunling Sang.
Hi, good morning. You can call me Shun, and I'm a family physician by training, and I serve as our chair for our family medicine department here at Riverside University Health System. I also serve as our medical director for ambulatory quality, and like you know, it seems like we all wear many hats when we do primary care. I also, in our county, serve as our deputy public health officer. And, I just wanted to just show, I'm so honored to be part of this group. There's a lot of great minds here. And, this primary care dashboard that we're looking to build, one of the things I look forward to is having that data to action to impact and why primary care is so important. I think a lot of you have said this, and what we do in primary care and how we can bring visibility to the importance of primary care to support our mission to improve the health of our patients and our community. So just really excited for this work, and excited to be part of this group. Thank you.
Yeah, thank you everyone for introducing yourselves. Really impressive range of expertise in this work group. We are really looking forward to incorporating all of your perspectives into this work, and we really appreciate the time you've committed to participating in it. And so before we move on to an overview of the Snapshot project itself, I just want to review the meeting format and some logistics, make sure we're all on the same page. So workgroup members, including HCAI staff and contractors, can provide verbal comments and questions during the meeting. These are public meetings that are posted on the HCAI public meeting page. So non-workgroup members, such as additional staff from your organizations, members of the public, or other groups are welcome to attend and to participate via the chat or via written feedback to the HCAI team. So you all should have received meeting invitations through 2026. If not, please let us know. And those meetings will be on the second Wednesday of every other month from 9 to 10:30, with a couple of exceptions. Today's meeting is obviously not on a Wednesday. Our first meeting next year on January 14th will be shortened to 1 hour due to a conflict with the HCAI Healthcare Affordability Advisory Committee meeting. And then the meeting on November 11th, 2026 will be rescheduled at a future date due to a conflict with Veterans Day. So all the meetings are on Teams and all virtual. We'll be using reaction emojis as you wish, and chat function has been in our other work groups a pretty robust mode of conversation. So please do feel free to use that option, and know that if we aren't able to respond to any of your chats in real time, we will track that input and use it to inform our work. Here we just have some etiquette tips to facilitate collaboration during these meetings. I won't read through the whole list, but just wanted to highlight the last point. And this reminder to step up and step back is a concept you might be familiar with. If you're someone who feels comfortable speaking up in groups, we welcome you to do so. And we also ask that you be mindful of opportunities to step back and make space for others to share. If you're not so comfortable speaking out, we invite you to step up and share your ideas. We want to hear everyone's voices in this group. And with that, I will hand it over to Miranda to dive into an overview of the Snapshot project.
Right. Thanks, Debbie. So next on the agenda is the overview. So I'll go over the Snapshot purpose, approach, and audiences, the timeline and deliverables that we have planned, and our principles for stakeholder engagement, including functions of the work group. We will also try to leave some time for questions at the end of the presentation, but we'll see if we end up with that. So to start, I want to highlight this vision for primary care delivery in California, because this is what grounds our work on the Snapshot. This was used by OCA and its Public Investment and Payment Work Group to guide decisions about what specific types of care should be included in OCA's primary care spending measurement. We will continue to revisit this vision of high-quality advanced primary care as we develop the Snapshot to help us align and focus the Snapshot to create a resource for stakeholders that promotes and measures progress towards this vision. So for some context on the Snapshot and how we got here, as you may know, the National Academies of Sciences, Engineering, and Medicine, or NASEM, report on implementing high-quality primary care, published in 2021, really started the momentum by proposing a U.S. national scorecard on the health of primary care. The intention of that proposal was that a scorecard supports tracking the implementation of the NASM Committee's recommendations and progress towards high-quality primary care across the country. In response to that report, the Milbank Memorial Fund developed a national primary care scorecard and has since released 3 annual scorecard reports. And then there are also state-level scorecards that have been developed in Massachusetts, New York, and Virginia. And then in California, the Primary Care Investment Coordinating Group of California, or PICG, which is convened by the California Healthcare Foundation, recommended in 2022 that California track progress toward high-quality primary care by developing a state scorecard. This idea has received broad support from stakeholders, and in 2024, CHCF funded efforts to explore primary care scorecard development, led by Dr. Diane Rittenhouse of Mathematica. This led to HCAI stepping forward to lead this statewide initiative, now the HCAI Health of Primary Care in California Snapshot. So with that background and context, the purpose of HCAI's Primary Care Snapshot is severalfold. First, it will create a shared understanding of the health of California's primary care sector, both statewide and for geographic regions within the state. Second, it will track progress toward equitable, high quality, and sustainable primary care for all Californians. Third, it will monitor the overall state's performance, not the performance of individual primary care clinicians, on supporting key elements of the health of primary care in California, including spending and outcomes. And finally, it will help identify gaps and challenges to inform action on access, workforce, investment, and other areas. In short, the snapshot will report on system-level performance across multiple domains to document the current status of primary care and monitor change over time and motivate action to improve statewide performance and achieve the vision for primary care in California. Okay. Our planned approach to the snapshot is not to collect new data, but to compile existing data from across HCAI and external sources to create a comprehensive picture of primary care in California. This would include both statewide and regional level data. Our initial plan is to focus on 5 key domains, which you see here: investment, workforce, access, quality, and equity. These domains align with priorities identified by NASM and other states, and they also reflect the expertise of HCAI in primary care. We propose using a phased approach for the snapshot, beginning with a static report on the key domains, then adding interactive features over time. The ultimate goal is to have both a static report and an interactive dashboard that are updated on an annual basis, and we'll review our proposed approach in more detail in the upcoming slides. And then lastly, in terms of the audiences for the snapshot, our current thinking is that the primary audiences are engaged stakeholders. Some examples are on the slide, not the general public. But although the public is not the snapshot's primary audience, there will be opportunities to develop messaging and content that increases public awareness of the challenges facing the primary care sector in California and, for example, the impact of investment and workforce development efforts. Included here is the Virginia Primary Care Scorecard, just as one example of a primary care dashboard. So on the slide, you can see how the dashboard tracks primary care utilization. There's that screenshot on the left. And then there are sections from one of their previous static reports that accompany the dashboard. They also include interesting geodata across the state, also seen here, which we hope to incorporate into the HCAI snapshot. So for the HCAI snapshot, the proposed key deliverables and timeline here show how these deliverables build on each other over time with our phased approach. So we'll start with the 2025 HCAI brief on the health of primary care in California, which we plan to release by early next year. This brief will, one, introduce and announce the snapshot, including our timeline and approach to the static and interactive snapshots and stakeholder engagement, and to provide an overview of the current state of primary care in California and identify the 5 domains for future snapshots. And I'll go into more detail on the content that we have planned for the 2025 brief in a few slides. Then in 2026, we plan to release the Health of Primary Care in California Snapshot as a static report. So this report will include indicators under each domain to be incorporated into the full interactive snapshot, and it will give an update on the timeline for development and release of the full interactive snapshot. In 2027, we plan to release the full snapshot, which will be comprised of an interactive data dashboard featuring the key indicators in each domain and still accompanied by a static report as well. And then from 2028 onwards, we plan to update the full snapshot, both the static and interactive versions, on an annual basis. And then I'll just quickly note that the proposed names of the deliverables, the content within each, and the timing of release shown here are tentative, and they may be revised as we move forward. This is our tentative timeline, and it kind of gives like a summarized look at what was on the previous slide. So you'll just see by year end 2025, we plan to complete the HCAI brief and begin stakeholder engagement, like with this work group. And then the release of the HCAI brief will be early next year. And then fall 2026, we plan to release the static HCAI Health of Primary Care snapshot report. And also at this point, we plan to finalize the snapshot domains, data sources, and indicators for the 2027 snapshot. And then by fall 2027 will be that full snapshot release with the interactive dashboard and the static report. In terms of the content for our 2025 brief, this is just an overview of all the elements in the content. First, the brief will just have an introduction with that announcement of the snapshot initiative and outline the content of the brief. Second is a background section that's going to summarize the importance of primary care, describe HCAI's focus on primary care dashboards, why we're doing this work, and the vision for primary care delivery in California. It will also point to other national and state examples of these dashboards. Third, in a state of primary care section, we will tell the story of primary care in California, including baseline and contextual statistics from existing reporting to highlight the current state of primary care across the 5 domains that we've identified. And then finally, the 2025 brief will outline HCAI's vision for the Snapshot project itself. We will describe the Snapshot purpose, approach, and audience, some of what I presented here already, highlight stakeholder involvement in the Snapshot development, and share a timeline for development of the full interactive snapshot. So for stakeholder engagement is a key element of this project. And our stakeholder engagement approach is multifold, guided by the principles of engaging a diverse set of stakeholders and soliciting their input to create a relevant and actionable slate of primary care indicators. So first, we will form a new stakeholder work group, this work group, to provide regular guidance on snapshot development. The benefit of this approach is to form a smaller group with primary care expertise to give us detailed and expert input as we design and develop the snapshot. As you saw on the membership slide and here with this graphic, we identified 6 stakeholder categories to engage for this work group: providers, health systems, health plans, purchasers, consumer and policy advocates, and academic and subject matter experts. Second, we will leverage existing HCAI stakeholder bodies, including the OCA Advisory Committee and Board, OCA Investment and Payment Work Group, Health Workforce Education and Training Council, and Healthcare Payments Data Program Advisory Committee. We will also collaborate with sibling state departments like CalPERS, Covered California, and the Department of Healthcare Services to seek their input. The goal is to gather high-level consultative input from these groups and hopefully garner broad support for the snapshot. And third, we will conduct individual key informant interviews with stakeholders as needed to elicit candid feedback on domains, indicators, preferences, and trade-offs, and also to fill any gaps and ensure diverse and representative stakeholder engagement across California's primary care landscape. So before we wrap up this presentation and agenda item, I'll review some of the functions of the work group. The purpose of the work group is to provide primary care policy data and clinical expertise in the development and implementation of the HCAI Health of Primary Care in California Snapshot. Work group objectives include offering a transparent public forum to understand stakeholders' priorities for the snapshot, engendering thoughtful, comprehensive, and balanced stakeholder engagement to ensure strong buy-in and smooth implementation, and providing expert technical input on the availability and feasibility of primary care indicators to include in the snapshot. And then on member roles and responsibilities, some of these include actively participating in meetings and preparing to the best of your ability, contributing your expertise, insights, and ideas, sharing the perspectives of your organizations and the stakeholder groups you represent, and when requested, soliciting feedback from colleagues within your organization and across the state. And then additionally, we've included some activities that will or will not be within the scope of the work group. I won't read through all of the points here for time, but I will note one of the key activities, which is that second bullet, informing the development of primary care indicators for the snapshot that will promote equitable, high quality, and cost efficient care. And this activity will kick off during our January meeting. Because the purpose of this work group is to provide expertise and illuminate stakeholder perspectives, the work group will inform HCAI's decision-making, but will not be voting on any final decisions or developing formal recommendations. And then this content here and on the previous slide will be included in a work group charter. We will share a draft of that charter in the next few weeks for review and feedback with proposed adoption at the January workgroup meeting. So you can look out for an email from me in a few weeks with that. And that I will pause here for any questions or comments just for a few minutes on anything about the overview or the workgroup. So please feel free to unmute or put your questions in the chat. Okay, I guess it was a very comprehensive presentation. I will then welcome Barbara Rabson and her colleagues to present on their experiences working on the Massachusetts Primary Care Dashboard. For a brief introduction, Barbara Rabson is the president and CEO of Massachusetts Health Quality Partners, or MHQP, and brings over 25 years of experience leading MHQP to improve patient experiences, advance health equity, and strengthen primary care. Also joining us from MHQP is Molly Topman and Julia Bonis. Molly is the Vice President of Quality and Engagement, and Julia is Program Manager. We are also pleased to welcome Erin Bonney, who is the Director of Health Informatics and Reporting at the Center for Health Information and Analysis, or CHIA, and helped lead the effort with MHQP to create the primary care dashboard. So with that, I'll hand it over to you, Molly, to take control of the presentation now, and Barbara and Erin to present.
Hey, well, thank you, everybody, and we are very pleased to be here. And want to congratulate you for getting to this important point. This is, I know it's a lot of work getting to the point where you actually have a formal group to have this incredibly important dialogue for action around what's happening with primary care in your state and how you can strengthen it. So I applaud your efforts to date to get to this point, and I'm very excited for you. And so happy to see so many friends and colleagues that I've worked with in the past over these years, either in primary care or other issues around quality. And I do serve on the Millbank National Scorecard work group with Sunita Mutha and Diane Rittenhouse. So it's great to be working with them again. So I'm going to share with you MHQP and CHIA's journey to create a primary care dashboard. We were actually the first in the country to create a dashboard and release one. We released it in January of 2023. Then the national dashboard was released, and then a growing number of states have released dashboards. So this is a really important growing movement, I'd say, of organizations creating dashboards. And as I've reflected on the role that our dashboard plays in Massachusetts, it's been really important for telling the story of primary care. And unfortunately, it's a story of great loss and crisis. But it also, I think about it, is sort of a mirror that reflects the healthcare choices, the policy choices that we as a state make. And so when you see these declining scores in, primary care investment, in primary care capacity, and performance and equity, you realize that there's choices that have been made on the part of the state that it has allowed that. So I think that's one of the really important roles of the dashboard, is it holds us all accountable. So let me go through a couple introducing our organizations, and then and give you a little more background, and then Molly's going to do a tour of our actual website so that you get a sense of how we decided to put our dashboard together. So MHQP, our mission is to improve the quality and equity of patient experiences of care in Massachusetts. We're a multi-stakeholder nonprofit organization and very data-driven. And we have, you might ask why an organization that works to improve patient experiences is taken a leadership role in supporting primary care. Well, it's because primary care has played such an essential role in patient experience. And when we became aware of how fragile primary care was, we're an organization that had been measuring the performance of primary care for many years. We decided we needed to pivot and measure the health of primary care. So that's how we got started on our journey. And we have a very important partnership with the Center for Health Information and Analysis. So let me pass this to Erin Bonney, and she can introduce CHIA.
Hi, everyone. I'm tempted to say good afternoon, but I'll say good morning to all of you, as I know we're in the minority over here on the East Coast. Lovely to see familiar friends and faces, primarily on HCAI and Friedman. A little bit of background on CHIA. So we are an independent state agency here in Massachusetts. Obviously, that's why we have an acronym, because you cannot be in government without a fun acronym for your agency. And CHIA really acts as the data hub for healthcare data here in the Commonwealth. So we have a variety of data sources and data collection, survey work. We house our all-payer claims data, in addition to a lot of aggregate data collections that we do directly with our healthcare insurers here in Massachusetts, one of which helps inform this dashboard and Massachusetts's reporting on spending around primary care and behavioral health services. And so really our work and CHIA's role is to provide the factual foundation, the data, to allow policymakers, legislators to make better informed decisions, so that when multi-stakeholder groups are having these really important conversations or developing plans or what are the options, everyone is working from the same set of facts, the same set of data, which is really where CHIA comes into play. So happy to speak with you all today. And do want to just quickly call out that 2 members of my team, Cassie and Joe, are also tuning in as well.
Thanks, Erin. So I wanted to walk through sort of how we got to our dashboard, and it started way back in 2018. MHQP had convened a stakeholder group roundtable on affordability, trying to identify ways to make sure patients get the right care at the right time in the right place. And we identified several barriers, and one of the barriers was access to primary care. And so MHQP, as I mentioned, we're multi-stakeholder. We have a clinician work council of can-do clinician leaders. Many of them are primary care docs. And so we went to the clinician council and said, we'd really like to talk to you about improving access to primary care. And this was 2018. And they said, no. And I said, what do you mean, no? And they said, you don't understand. We can't take on one more thing. that we're so overloaded. We just can't talk about increasing access. And I was like, whoa, if that is true, we should be shouting from the rooftops, look, primary care is in trouble. And so MHQP started convening folks to talk about primary care. And then in 2019, our then governor, Charlie Baker, filed legislation to increase spending on primary care and behavioral health. And so when this legislation was filed, HCAI said, okay, we have the all-payer claims database. We should start tracking how much we're spending on primary care and behavioral health. And so that put them into motion to say, well, if we're going to increase it, we need to know what we're spending now. And so that started. And then in 2020, MHQP convened a task force on primary care to talk about what the future of primary care should look like. And then COVID hit, which was, of course, incredibly devastating for primary care practices. And you had no idea what was going on in terms of these practices. We knew that were already fragile before COVID. And so as we looked to say, well, how is primary care doing? There was no place to go in the state to say, okay, we knew primary care is fragile. We know COVID hit, things are much worse. How do we know how things are doing? And there was no place. So we said, it's that time we began this pivot at MHQP and said, look, we've been measuring the performance of primary care for years. Let's pivot. We need to measure the health of primary care. And so we started to talk to all our stakeholders about if we were going to measure the health of primary care, what would that look like? And came up with literally hundreds of potential metrics. And then in 2022, we began to work with HCAI because, as I mentioned, HCAI had started gathering primary care spend and had actually issued a report on primary care spend. And so together, we decided that we were going to create this dashboard. And we agreed that we would focus on 4 domains of care. And now it's broken into 5, but it's really primary care investment or financing, the capacity of primary care, which I think you guys call workforce, performance, which has been broken down into care and to access, and then the equity of primary care. So very similar to the metrics or the domains that you have identified. And I think from a policy standpoint, that makes a lot of sense. One other domain we've thought about but haven't included is the market domain, to track the number of practices that are bought out by private equity, the number of practices that are going to concierge medicine, the increase in urgent care because primary care is not available. That's something that we don't yet have, but it's something you might consider. And so in January of 2023, we released our first dashboard in the nation. And I was so hopeful that once the data came out, everybody would jump into action and say, okay, our state's in trouble. We need to act and support primary care. But unfortunately, that did not happen. We released our second dashboard in 2024. And just so you know, the first dashboard was pre-COVID numbers and then post-COVID numbers. And in every single case, every domain was getting worse. And then that showed the trend continued on the second dashboard. And it was getting a little bit frustrating to think, okay, what's the point of a dashboard if people aren't jumping into action? But we worked really closely with the media, and which I'll go into later, and got the message out. And then we had an inflection point at the end of 2024. We passed legislation to establish a primary care task force that I sit on for MHQP, and she is a member, and a lot of organizations are the counterparts of your task force here. And that task force is charged with coming up with specific recommendations. So if you go to the next slide. Let me pass this to, these are the, I'll pass this to Molly Topman, and she'll go through sort of the sort of what kind of data is in our dashboard, and go through quickly sort of the actual dashboard itself. I will say, if you have any questions at any point, just raise your hand or put it in the chat. We're happy to answer as we go along.
Great, thank you, Barbara. And I'm just putting into the chat a link to our dashboard in case you want to check it out while I'm presenting. So our and HCAI team, of course, chime in too if there's anything you want to add. So the dashboard, as Barbara mentioned, now has 5 domains. So you can see those on the right: finance, focused on spending, capacity on the workforce and pipeline, access, and then care is utilization and quality. And then we have equity metrics. So let me just walk through the components and then I'll show you. So there are several elements to our dashboard and sounds somewhat similar to some of what you all have planned. So we have a static PDF. We have an interactive Tableau. We have a technical appendix and we have a data book. So 4 pieces to the dashboard. So when you pull it up, you'll be prompted to click into one of those options. And then I just wanted to also highlight our data guidelines as we look at the dashboard. Some of this will become relevant. And this is also something that we found really important to have. So, these are just a few, but to give you a sense, we have prioritized publicly available or generally already accessible data to HCAI or MHQP, low or no cost associated with the data. Really important that we had documented specifications for any data source. We have included data sources that are updated on some regular cadence and that we have the ability to trend. And then as we publish a dashboard, ideally any data point included in the update is no more than 2 to 3 years old, and still being able to trend. We look at statewide reporting, and you'll see in the dashboard, ideally we'll look across at a minimum commercial and Medicaid if we're able to. And then where possible, we do use additional sources for validation. So I'll give you an example of that as well. All right, so let me just share my screen. Okay, can you see that okay? Great. All right, let me just move your faces. Okay, great. So in the blue box here, this is where you can click into those different elements of the dashboard. So the static PDF and so on. So let me just show you first the static PDF. So I'm not going to go through all the details because we have limited time, but just to give you a sense of what this looks like, the first page of the static PDF has a key highlights page that just gives a little snippet of what's in each section. So for example, for finance, you can see there's a little highlight here that in 2023, Mass Health, our Medicaid plan, had the highest percentage of spending on primary care, whereas commercial saw a continued decline, unfortunately. There's a context page, which has several at-a-glance health outcome measures and market notes. And then this is what the domain page looks like for finance. So where we just saw that little snippet, this is the full page. So here you can see our measure for primary care spending and broken out by commercial, Medicaid, Medicare Advantage. And we have 2 years of data here. And let's see, just for another example, I'm going to scroll down to care. So here's our care page. And you can also see we have these little icons up top that are hyperlinked, so you can just quickly, easily jump to the different static PDF pages. So here you can see, for example, childhood immunization on the far right. You can see a dip from 2022 to 2023. We also have some patient experience metrics here. And lastly, equity, which takes measures that are in different sections and breaks them down by race and ethnicity. So for example, difficulty obtaining necessary healthcare is in our access section, but this is also showing it by race and ethnicity. So for example, in 2023, 41.2% of residents reported difficulty obtaining necessary healthcare. And then you can see in red where 48.3% of the other or multiple races group reported a higher percent of difficulty.
Okay, there's so much more I could spend time clicking around, but I just want to briefly show you the other elements of the dashboard. So this again is the static PDF. There's the interactive Tableau, which drills into not every measure, although we are adding measures. The CHIA team has been adding measures. So we have a drill down. Let's see. So if you click into finance, we had the finance static measure on the static PDF, but here you can click in and see more detail by payer, by physician group. We also have some stratifications for equity, so you could look at ED use by family income. And then we also have a regional view, which gives some nice drill downs. Okay. And sorry to be going somewhat quickly, but we want to make sure we leave time for questions. The other piece that I think is critical is the technical appendix. So for every measure in the dashboard, there is a detailed description of the measure, numerator, denominator, the data source, the cost, when it was released, if we did have a validator. So really helpful detail for those who are wanting to dig in. And then lastly, for the real data nerds, the data book. So CHIA beautifully organized this data book. Just going to go to the index. So for any measure, I will click right, you can jump in and see if we have additional data. You can see all the years that we have available, any of the stratification. So this is child mortality. This was in our context page. We just had one number. This gives you much more detail. Okay, so I think I covered everything on the dashboard. Anything else Barbara or the CHIA team wanted to say about that?
Well, one thing I would say, thanks, Molly. And you know, Molly sent you the link so you can look at this yourself and follow up with any questions. But the importance of bringing all this data together, because as I mentioned, you know, CHIA had put out primary care spend, but primary care spend on itself is not as compelling as looking at, okay, primary care spend is declining as well as the number of primary care docs leaving primary care is accelerating, the number of you know, the equity performance is going down. So when you put this all together, it's very powerful. And I also think it's very powerful that CHIA and MHQP partnered on this, because CHIA is, as Erin said, the state data agency that the government, the state government goes to, the legislature looks to CHIA for publishing data. So it's the go-to place for the legislature and policymakers. MHQP, on the other hand, has all these councils, and we sort of have a lot of street credibility. We understand what's going on with primary care and what's important to put on the dashboard, and also a sense of, you know, we're able to kick the tires on data. And if some of the data didn't reflect what was really going on in the environment, we were able to know that. And so we wouldn't put any data in that didn't reflect what was going on. So if the next slide shows you, in addition to, or to support MHQP and CHIA working together, we had an advisory group similar to yours that to help us identify measures and explore gaps in primary care and prioritize, because one of the challenges you'll find, especially I think in California, when you have so many great resources for metrics, the question is, how do you prioritize what should go on the dashboard so that you get the most important thing? And Molly shared sort of our criteria that we've been using. If you go to the next slide, I wanted to share some of the media coverage that we had. As I mentioned, the dashboard, while it took a while to get policymakers to act, the public responded immediately. The Boston Globe and other media outlets provided coverage pretty much on a very regular basis from the time we put out the first dashboard. And then there was, and then it grew. And so in fact, the Boston Globe, when they put out their first story about the dashboard, they had hundreds and hundreds of reader comments. And I mentioned that to the reporter about so many people writing in about their experiences. And so the Globe ran a survey, and they asked their readers to give their stories about, challenging access to primary care. So that led to another article, and it just sort of snowballed in terms of, the public getting exposed to all of this. And if you go to the next slide, this was the editorial in the Boston Globe in May after our second dashboard came out, that, we asked too much of our primary care doctors, 26.7 hours to be exact, and that, we really need to act, and this dashboard is really important. And so it was after that, if you go to the next slide, November was really our inflection point. And so 2 dashboards had been released. We had at the Health Policy Commission cost trends hearing, which happens every year, our governor for the first time came out and said, we need to invest more in primary care. So that was, for her to say that was really important. We had a couple state laws passed, including the legislation to establish the task force. And the governor not only continued to advocate on behalf of primary care, our Health Policy Commission came out with a second report on the dash on our situation in primary care. So these and the next slide is the charge to our task force, which is not exactly, the same as your task force. In some cases, you're ahead of us. In cases, we're ahead of you in terms of, sort of what we've accomplished. But these are the charges, and it spans over a period of several months going into next year. And the task force is launched. We're making progress. And it is, we started with the easiest stuff. So it's getting a little bit more challenging, but the idea that there is an opportunity to have this important dialogue about primary care, as I said, that it's expected that the state is looking to this group for recommendations is just really important, because we went a couple years with no dialogue, and that was not helpful at all. So you really need the dialogue to move things forward. So let me pause before we go to recommendations and lessons learned. And I mean, we're open to asking or answering any of your questions or comments. Actually, if you go back to the last slide, maybe, and then we'll get to the lessons learned. Raul?
Yeah, hi, thank you. Thank you for the presentation. I am in a rural community based hospital-based clinic. And I'm wondering, how did you guys, or in the dashboard, is there rural versus urban, whether it's a designation or not? Did you guys look into, so some of the more underserved areas are rural? Just wanted to see what you guys enlisted in here.
Yeah, it's a really good question, and I'll start, and Molly and Aaron chime in. We don't say rural urban. We have MHQP, Massachusetts has some rural areas, and we sort of know where they are. They're mostly the western part of the state, and so we do track, as Molly showed, some of the geographic areas that, so you can look to where we're talking about, but it's not, we don't designate rural and urban, so we're not explicit about it. But I think it would be a good idea. So I think that's definitely worth doing. I'm not sure we have the data other than the geographic data, and so it depends on our data source. Some of it we do have it by zip code or by census tract, and then we can track that. But not all the measures are able to stratify that at that level. Erin, do you want to add anything?
Only to say, thanks for the comment. We've heard that as well. And to, it's on our list of stratifications to explore. To the extent we have zip code, we could do it. But as Barbara said, Massachusetts is pretty small relative to California. So really, when we're looking at the map, policymakers and engaged stakeholders in Massachusetts know that our rural areas tend to be kind of the left half of the state.
Thank you all. Thank you.
Thanks for the question. Did I get your name right?
Yes, Raul. I'm in Central
Sean.
California. Thank you.
Nice to meet you.
Hi, I'm Shun Ling Sang from Riverside, and you can call me Shun. And thanks so much for this presentation. It was fantastic. I had two kind of things that while you were talking about the dashboard really hit me. One is, I like the increased spend that we're seeing in primary care, especially I think in the Medicaid space. And I wonder if the dashboard tracks where that money is going specifically, that lifts the burden for primary care, and how that's articulated, I guess, within the dashboard and what's being tracked for that. Because I do think, I think in primary care, we see money coming to primary care. I wonder, that's my wonder. The second was regarding measuring the markets. I think that's something that we in primary care, amongst my, primary care circle, we've talked about, the difference between kind of a primary care led practice versus a more business led practice, and how that contributes to maybe how we prioritize primary care. I would argue sometimes access and quality are pitted together if you think about the same thing, productivity versus quality, right? And which is a big burden in primary care. So just curious how, if that could be a future measurement in California, if that's something we can consider bringing.
Yeah, thanks for the question. And the first one, I think that's like the $21 million question, is how the money flows. Because in Massachusetts, we have our Medicaid program, Mass Health. We've invested a lot to support primary care. And so looking to where the dollars flow once it gets to the ACO level is really important. And there's more transparency on Medicaid than there is on the other payers. And so, for example, on the commercial payers, Blue Cross has literally millions of dollars of incentive payments for primary care, or for systems that are primary care measures in the alternative quality contract and other vehicles. And one of the biggest challenges is that the money sort of gets stopped along the way as it filters down. And so, how much money actually gets to the practice, and there's zero transparency about this. So Senator Cindy Friedman, who chairs our healthcare, the Senate Healthcare Committee, and sits on the task force and is responsible for the task force being enacted. This is a pet issue of hers and many of us on the task force, but it's really difficult. And so the challenge is, we have the Division of Insurance at the table. We've got the Health Policy Commission. We've got the HCAI. We've got a lot of government agencies that have some authority to gather data, but we haven't, one of the deliverables that has not yet been finished is to recommend sort of the data requirements of organizations so that you can better track that transparency, and so have a better sense of what's filtering down. Did I answer that part of your question? Was that sort of, does that answer the first part of your question?
It does. Thank you. And I'll add a little bit of my additional kind of wonder there is, I wonder, in addition, is if it's coming through incentive payments through ACOs or through, MCPs or whichever, incentives come with additional burden to primary care. So, I think it's not just incentive payments, but rather how are we transforming primary care using dollars that are not tied to additional obligations in primary care. I think that's the hard part. So just, throwing that out there for consideration as well.
Yeah, that's another really important issue that the task force has really grappled with, the administrative burden and how problematic that is to keeping primary care docs and driving people out. And so we have talked about a lot of administrative burden measures. I don't think, it's still something that we're working on. But if there, I think that's a really important thing to incorporate is, sort of what's happening with primary care in terms of everything you add, even if it's intended to support, sometimes it is, it is an added burden, and it all hits primary care. So one of the things that we might look is, how many primary care practices are actually implementing AI for ambient, note taking, or, things like that. So I think there's a lot in the sort of the burnout arena or administrative burden domain that could be added. On your second question, it was around a domain on the market.
Yes. Yeah. So I was just curious, when we think about primary care burnouts, are we seeing a difference between practices or systems that are primary care physician led or physician led in general versus administratively led by, I would say a non-physician who's really focusing on the productivity and bottom lines, right? And so I think there's a difference in culture, if you will, when there's practices like that.
Yeah. And one of the measures we don't yet capture, like there's no data in Massachusetts right now, is the ownership of the practice, because so many of our practices are owned by hospitals. And we know there's competing priorities when a hospital owns a primary care practice. In Massachusetts, some of our best multi-physician groups have been bought out by Optum. And so another one just was. And so that we're not really tracking venture capital backed practices. And so, and independent practices are sort of leaving, and many practices are moving to concierge. So it's a trend that I think is really important because it all impacts access. And so I think those are really important things for you guys to consider. Erin or Molly, would you want to comment on those questions?
No, it seems like we have a couple other questions, so I want to be cognizant of time.
Yeah.
Okay, great. Good. Oh, Carlina, hi.
Hi, Barbara. Nice to see you. Thank you so much, you all, for being such great exemplars for us here in California. I really, really appreciate the presentation. I was curious about dissemination, if there were any lessons you learned and sort of how you got the word out about the dashboard. You got some great coverage, and what contributed to that uptake, and then on what worked and maybe what you wish you could have done. And then, very different note, I'm curious if measuring continuity has come up as a conversation.
Yeah. Thank you. In terms of dashboard dissemination, my goal was that when it came out, we wanted it to be a pull, as opposed to, us having to push it out. We wanted to create the awareness and that people would be eager that it was coming and that they would want to get it. And so, it's like, yes, it's finally out there. And so we met with lots of specialty societies and, all kinds of primary care groups and advocacy groups ahead of time to let them know about the dashboard and say, this is coming and this is, we think it's really important. And so there was a fair amount of awareness, and your group, obviously you touch a lot of people. So that, with the membership of your group, you'd be able to really activate that. And so I think that was one really important thing. And then, the media, it was because the media covered it and really kept covering it. I mean, sometimes it's like, oh yeah, we covered that, it's like, no, but there's more, and it's, the story continues. And so sometimes it's challenging to say, okay, well, what's new about this? And, to keep the discussion open. But it was frustrating for a very long time before there was action. But I think that really helped. And Shia, and Erin can speak to this, has these normal distribution channels because they issue these reports. I mean, they issue a lot of reports. So Erin, do you want to talk about that?
Sure. So prior to publishing the first primary care dashboard, CHIA had already been measuring spending, primary care and behavioral health services. So from our perspective as a government agency, our release process looks pretty similar, where we issue a variety of materials, but our the list of people that receive our emails with all of our reports, I think is pretty lengthy at this point in time, having been in existence for, I think, 13 years and really establishing ourselves there. So we also are able to rely on, I think, our reputation of CHIA's issuing a report. Here are the key findings. This is something to look at.
Thanks. So Sunita, oh, I'm sorry.
Hi, Barbara. Yeah, I put it in chat as well. One of the challenges that always comes up is that it's really delivering primary care is a team sport, particularly now. And so wondering what you can tell us from your efforts to try to consider ways to measure that and what guidance you would give us.
Yeah. Well, honestly, I would say that you have way better data on workforce because of the work you do in your center. It's been challenging to get data on non-physicians. We have some of them are national databases where we could pull from Massachusetts. Others are some, studies, that are done in Massachusetts by the Health Policy Big Commission, but sometimes they're one-off studies. So, they don't really qualify for the dashboard. So I would say way more energy has to go into this. And we don't have a good measure of team. We have, MHQP's patient experience survey results that talk about, sort of the care patients are getting. Was it coordinated? I think that was one of the questions about, comprehensiveness but we don't have great measures. So that's one of the things that you'll run into is that you have a concept, it's really important to get out there, but you don't have the data, and then you have to invest in it, and it takes some while, a delay. But I think that it is a really important thing. And I think the public still doesn't understand, team care. Edward?
Yes. Well, thanks so much for the feedback and insight. I was just wondering how you may have kind of worked through how to appropriately define primary care and primary care services, only because sometimes, depending on what's grouped in the primary service category, a specialist, maybe even a non-PCP, maybe a traditional or non-traditional clinician or practitioner may also be providing direct or indirectly related service. So I just am curious as to how those conversations went and how the providers reacted to what was included and excluded in those definitions. I only share that because when, at least from my experience, when data is shared, everyone starts interpreting the methodology pretty quickly. And I just want to make sure that we all feel aligned, that when we say one thing or another, that we can stand behind it.
Yeah. Well, let me start on that answer, and I'm going to pass it to Aaron because they actually defined primary care before the dashboard, and so it was sort of pre-existing. But in terms of on the dashboard, we wanted to put a definition of primary care, and we actually struggled because so many of the definitions are aspirational. And we wanted people to recognize that this is the care they get. And if you go into everything that should be happening, but isn't, that's not really reflective. But we ended up going with the NASM definition for primary care. And the first deliverable of the primary care task force was to define primary care. And so it was sort of an easy question. Well, it's easy and complex at the same time. It was easy because CHIA had already done it. But it's more complex because, as you point out, it sort of depends on the case, the use case of it. Because if you're saying, okay, we're going to invest 15% more in primary care, and all of a sudden, well, people say, oh, well, I do primary care, but it's not, what we think of as primary care. You want your definition to be narrow enough. On the other hand, there are, patients go for services like, so for example, and I know this is a bit controversial, but so urgent care, like a lot of patients, when they can't get access to primary care, they'll go to urgent care, but the task force doesn't want to include urgent care and primary care because it's not primary care, yet patients are going there for those kind of services. So keeping track of what's happening in terms of utilizing urgent care, and is that going up? That's important, but it's, you don't want to put it in the definition of primary care. So there's, I'm going to pass this to Erin because there are some peculiar things about or the Massachusetts definition, including behavioral health and maternity services. So Erin, you want to share with that?
Sure. So as a quick note on the dashboard, due to the variety of the data sources that we collect our measures from, so some of it is direct from HCAI and our calculations and data that we collect directly from the payers. Some of it is patient experience survey that MHTP does. Other is survey direct to the residents of Massachusetts that HCAI runs. There is certainly opportunity for variations among primary care in terms of like, if you're asking a resident, like, were you able to get the care that you needed in a timely manner? What they're thinking of might vary than like the formal nuts and bolts of how HCAI has defined it for our particular methodology. So I would say broadly, that's something to perhaps keep in mind in the dashboard, but also like as a snapshot or as a dashboard is designed to capture, high level what's going on across the domains. It will be fine. In terms of a specific definition of primary care for our purposes of measuring spending on primary care, HCAI, yes, thank you for HCAI staff for popping your definition. Ours is pretty similar to other states where broadly it is defined by the types of services you're receiving and the taxonomy of the provider that is rendering those services. And so this is our attempt at excluding maybe a specialist that's providing like an E&M, but we do want to capture, we want to capture adults that are getting their flu shot in whatever setting that is taking place, because hopefully everyone is getting their flu shot. But we also want to ensure that we're looking at the providers themselves and really capturing, internal med, PAs, NPs, both physician and non-physician. So looking more holistically at those care teams of who can and is often a primary care provider. So in terms of a methodological definition, and I believe ours is pretty similar to California and a lot of other states, where it looks at a combination of services and who's giving the service. And so when we talk about a primary care provider, we're really referring to your internal med, general family practitioners, pediatricians, kind of the pretty common list of taxonomies that I think would come to mind for primary care. We do also include community health centers, rural health services, school-based clinics as like primary care providers themselves, recognizing the proportion of residents that get care there, and also wanted to make sure that we're including NPs, PAs, and all of those specialties as well. We do include OBGYN as a primary care provider for certain services, recognizing the role that OBGYNs play in preventive services. Often, your OBGYN will act as your primary care provider, but wanting to exclude labor and delivery, but include all the other things. And so we are kind of continually looking, making sure that we're aligned with other states. That was very high level, but I hope that answers your question.
So Debbie, we should do a time check because I see there's one more question and a question in the chat.
Yes. Why don't we? Yeah, we have time for one or the other. Lessons learned, or what question do you have, Susan? Do you want to ask your question? And we probably need 2 minutes to just wrap us up after that.
Yeah, I'll try to be quick, although this is probably a little bit complex. But the question is really, as everyone is speaking, this idea of being able to actually identify data that it satisfies all the requirements you've listed for those investments in primary care activities that may not be billable, that may not come through claims, the care management, the complex care management, however it is that potentially those ACOs or IPAs, or whether it's maybe even at the health plan level, are actually investing, but are not counted within those claims data. So can you just speak a little bit about how you manage that with your dashboard? and how you made those decisions would be helpful.
Yeah. Erin, you want to start?
Yeah, so I'll hop in and say we haven't figured it out yet. So if you guys do, please let us know. We're thrilled to take lessons learned from all of our other friends that are joining us in this work. So yes, point well taken. We recognize we also struggle with that. And I mean, part of it is like we want to put out what information we have that is reliable and timely. And so if we waited until we had perfect data for all of the measures that we wanted, we would still be working on a list. So it is an iterative process, is definitely a lesson learned that we would issue. It looks like HCAI is a pretty good on-ramp for PDF first and then adding in an interactive. We did the same thing. So it's something honestly that like we're still working on. We have some data and we're investigating with other state agencies. What we're always looking for new data sources or where there might be data, even if it's a proxy measure. So even if it's not perfect, is there something that makes some form of inroads? So unfortunately, we don't have any, brilliant insight into this beyond we are in that trench with you.
Thanks, Erin. So I'll just quickly, these are some recommendations and lesson learned, but obviously we're happy to talk more about this. I already mentioned the public-private partnership and how effective that was. Determining who the audience was. I mean, you said stakeholders and it had a huge laundry list. I think you might have to prioritize in terms of, which ones are the most important or how do you reach, which ones. The idea that we have a wide range of stakeholders giving input as you do. I think that was really important for us. And one example was we got some data from our Board of Registration of Medicine, and they said it was about how many practices are accepting new patients. And it was some ridiculously high number. And there was no way it was a true number. And, when there's nothing, when you respond to the Board of Registration survey, nobody's going to follow up and say, you aren't taking data. So you just have to be careful when you get data and really test the credibility, because you don't want to lose your credibility. And if you put in some bogus, some numbers that don't reflect reality, you'll lose some credibility. I already mentioned the media, and that this is going to take longer than you think. But again, you guys are ahead of us in terms of the policy action. So it's, it's weird. And then from an operational standpoint, coming up with these design principles early on will help you down the road. And as Molly shared, this technical appendix and the specifications, that's something that gives the report a lot of robust credibility. And then there was a lot of strong project management jointly across MHQP and HCAI. So with that, we'll give you, thank you for inviting us. It was, and good luck. We're rooting for you. And if we can be of help, let us know.
Thank you so much, Massachusetts team. We really appreciate it. And we invite the work group to compile questions to follow up with them after the meeting, since we could go on for a while. But in the interest of getting you out only maybe 2 minutes late, I will just wrap up very quickly with this timeline of what we'll be focusing on over the next year. So by early January, as Miranda already said, we'll be releasing our 2025 brief that'll be essentially an announcement of the Snapshot project. And then this work group, through most of 2026, will dive in deep to the work of developing and selecting primary care indicators for the 2026 Snapshot report. We also welcome your input on our proposed approach to the Snapshot. We've presented our current thinking, but we welcome your suggestions about the timeline or the content of the upcoming Snapshot data products or any other aspects. So at the end of 2026, we'll be reviewing with you all the report to be released sometime in late 2026, and then moving on to kind of iterate and further develop indicators for 2027. So again, we'll be working in the next couple months on the HCAI brief. We'll send you the work group charter, so look out for an email from Miranda about that. And then in early 2026, we'll start working on indicators, and also happy to bring more information on the OCA primary care definition, because that's several people have brought that up as questions, so we can discuss that more at a future meeting. So with that, I will adjourn our first meeting of the HCAI Primary Care Snapshot Work Group. Really, really appreciate all of you for taking the time to participate in this, and looking forward to seeing you all at our next meeting on January 14th.